disease is present or not, and always check for the duct patency and check the IOP. And then we can decide whether a pre-op anti-VEGF is also required. And a few signs which actually are poor prognostic indicators are shallow anterior chamber, membrane over the pupil, irregular pupil with posterior synechia. When many of these cases, when they present with stage 5 ROP, a B scan is mandatory, basically because you need to see what is the posterior retina looks like, whether it is posteriorly closed, whether it is open, or if the baby is presenting little late at 4 or 5 months, then the baby might already having the complication features like subretinal exudates or crystal deposits. So these, when you see these subretinal deposits, that is again a poor indicator. So the most common indications for surgery are stage 4A and stage 4B, stage 4B ROP, stage 5 ROP. In some cases, babies present with vitreous hemorrhage which preclude the delivery of laser. So in some cases where the B scan shows that the retina is not detached or anything, still we have an option to give anti-VEGF these days. And sometimes post-laser, when the laser is very intense, on follow-up, some babies very rarely develop breaks related to laser, and they can develop a combined retinal detachment. So when you deliver the laser, you have to monitor the intensity of the laser burns. And the surgical options include lens sparing vitrectomy, especially in stage 4A and 4B. 4B in the zone 2, you can plan for a lens sparing vitrectomy. But in the diseases with stage 4B, especially in zone 3 and stage 5, you will have to sacrifice the lens, so that is lensectomy with vitrectomy. And in diseases with the traction, like a stage 4A in the zone 3 and all, you can get away with just a belt buckle. And sometimes babies present very late, actually, maybe like at 6, 7 or 11 years, with some breaks in the periphery leading to a retinal detachment. So in those cases, you can settle it with a scleral buckle also. The main difficulty is because of the small size of the globe, it is very difficult instrumentation. The pars plana is undeveloped, and so when you enter, especially for a lens sparing vitrectomy, you are entering through the pars plicata because the lens is very large and we don't want to injure the lens. The adhesions and the vitreous is very gel-like, the firm adhesion between the retina and the vitreous. And when you place these sclerotomies, you have to see that which area the retina is dragged, because you might induce an iatrogenic retinal break if you have not done a very careful pre-op evaluation. If you create a break, then it is like you have lost the eye type in these cases. So a good pre-op evaluation, and then avoid putting the sclerotomy or entry in an area where there is no drag. So the surgeon may have to sit on the nasal side or a temporal side to operate one eye. And you have to remember that in these babies, the pars plana is underdeveloped, so you need to position the sclerotomy as per the age of the baby. So this is a video of a stage 4A ROP. You can see that the retina is lifted along the arcades. And temporally, you can see that both the arcades are adhered together. There is a connection between the superior and inferior arcade lifted vessel. So basically, what you are tackling is the traction. That is the reason why there is an anteroposterior traction lifting the retina from posterior towards the retrolendal space. So you need to release the traction, this retino-retinal adhesion, that is between the superior and inferior arcade, then between the retina and the disc, and from the retina and the disc towards the retrolendal space. And you can see that in this periphery, actually, the retina again is detached, and you can see that traction between the detached peripheral retina and the disc. So you need to release that traction also. That is why when the baby goes for stage 5, you will see a trough in the periphery. That is the peripheral lifted retina and the ora serrata. There will be a gap there. So the aim of the surgery is to release these tractions, and you don't expect the retina to settle down on the table. It will take long time for the retina to settle. And this is a case of stage 5 ROP. Here you need to see that because we are planning to remove the lens, the entry is through the root of the iris into the lens, and after removing the lens, actually you tease the membranes using 2 instruments actually, because you need to enter the retrolendal plane, and the retina is actually dragged and sitting just behind the retrolendal plane. So by doing removing these retrolendal membrane, and as I mentioned, there will be a stalk from the disc to the retrolendal space. So you need to dissect and open up the funnel from the disc, and in the periphery, as I mentioned, there will be a trough. So you have to release the connection. So at the end of the surgery, you don't expect the entire retina to go back, but it is just to release the traction, and it will take months for this retina to settle back. And you don't expect a 6/6 or 6/24 vision in these babies. If the babies can see at least close to face hand movements or even PL is much better than NNPL. So the aim of the surgery is release the traction, and recovery is gradual over years. But when we operate cases like stage 5, the anatomical success may be range between 15 to 60%, while if you get a baby to operate at a stage 4, the anatomical and success would be up to 90%. And post-op is very important because you need to give spectacle corrections, and you better, if you are operating unilateral and especially lens sparing, avoid any cycloplegics. These babies require repeated general anesthesia, repeated retinoscopy and glass correction, and IOP also need to be monitored because they can have secondary glaucoma. So your care for babies doesn't stop with surgery. This baby has to be followed up lifelong, and you need to have a collaboration with your pediatric ophthalmologist and take good care of these babies. Thank you.
Thank you, Dr. Divya. That was an excellent talk.
If any of you have any doubts or